Apologies for not really releasing the other videos concurrently. Had to go through a lot of stuff. A lot of you people have been requesting to learn about the treatment guidelines and the regimens, and a bulk majority have no idea of how the drugs actually work and why we combine the drugs in a specific way. Why certain drugs can be given with other drugs. That's how I decided. Let's have an interlude and talk about HIV drugs. Grab your piece of paper, grab your pen, and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at HIV drugs as a concurrent episode that we're going to be running parallel to our HIV week. So I shall call it as an interlude because it's in between the parts that we've already done. If you haven't yet looked at HIV basics, head over there and have a look at that. Diagnosis of HIV in adults, and that's pregnant and non-pregnant women as well as children. Have a look at that. I've already released these videos on the channel. Today we're going to be focusing pretty much on HIV drugs as a prerequisite for you to know about the treatment guidelines in adults, the treatment guidelines in pediatrics. I'll talk about a lot of the pharmacology of different drugs that we use in HIV. So this is a very, very important lecture to watch before you actually learn about the treatment guidelines. In view of our new style of lecturing, we start off with a warm-up question. Which other tests apart from PCR can be used to confirm acute retroviral syndrome? A. Enzyme immunoassay. B. Rapid HIV 102 test. C. P24 antigen. D. An oral home HIV testing kit. E. Western blot. I covered all these things in my previous lecture, so you can write your answer down, and then of course I will give you the answer at the end of the lecture. If by any chance my PC actually decides to turn off, please bear with me because I'm at a different recording space and my PC isn't really plugged into the electricity. So why do we select certain drugs and we don't choose other drugs in the HIV regimen? The drug selection is based on certain things. The first and foremost thing is we want to avoid using two agents that pretty much work the same way. Two agents that are going to be working as the same nucleoside analog. I'll explain this a bit later on when you look at the different classes of drugs. Two is want to avoid any overlapping side effects, any overlapping toxicities. For example, if two drugs are hepatotoxic, it means if you co-administer them, there would be actually their toxicities would be rather additive and it would make situations worse. Then of course we want to also avoid drugs with genotypic and phenotypic characteristics of the virus, different types of effects on the virus. We want to combine those drugs such that there is an additive way of using this drug and they're not really counterproductive. Then the third reason is that the patient factors, so the other diseases that may be present, the symptoms that are present, concurrent illnesses, and of course the impact of drug interactions and the ease of adherence to the regimen. Most of the HIV drugs are going to be either given as once a day or 2 times a day. It's very rare that you'll get anything that's going to be given 3 times a day. And most of the drugs that were given 3 times a day are not really commonly used in the regimen because we want to make it as easy as possible. It's easier for a person to remember that they have to take a drug each and every single day at the same time, as compared to taking it out 3 or 4 times a day. And of course, the goal of our therapy is to virally suppress this individual. So we want to restore the immunological function. We want to reduce the HIV morbidity and mortality. We want to improve the quality of life. Then, of course, we can do what is known as viral sensitivity testing or resistance testing. We should actually do this before we start treatment. It's not really a set in stone thing, such that if you do not have any resistance results or viral sensitivity, you can't start a patient on treatment. No. You can start them on treatment, but before you actually switch them to different drugs, make sure that you do your sensitivity testing. Then, of course, some common side effects include GI upset, which is going to include things like diarrhea, vomiting, hepatitis, especially with nevirapine, skin manifestations like mild rashes. In some rare cases, you may have hypersensitivity or even Stevens-Johnson's reactions, or even toxic epidermal necrolysis. These are very, very severe hypersensitivity reactions. You may have metabolic disorders like lipodystrophy. There's going to be fat reduction in the periphery, for example, the head and the limbs, but there's going to be gain in the central areas. This is very common with the nucleoside reverse transcriptase inhibitors. It's very common with the protease inhibitors. Then, of course, you may have diabetes, you may have dyslipidemias, which are very common with the protease inhibitors, but possibly could also occur with other groups of drugs. Now, before the year 1987, most patients were dying from HIV. Most patients were on HIV, who had HIV rather. The treatment was rather focused on decreasing the occurrence of the opportunistic infections, and this actually correlated with a very high mortality rate, very high morbidity rate in HIV patients before the introduction of the drug or approval of the drug zidovudine. Then, now that we already know the viral replication cycle, which is why it's important that you must watch the first and the second parts of this video before actually watching this video. It's very important to understand the life cycle of the virus, such that now we can actually combine certain drugs to suppress the HIV, and we can also restore the number of the CD4 counts. It may not get back to normal, but it will increase, and the chances of this person getting opportunistic infections and progressing is much less, such that even the life expectancy of the person is almost near normal. So we use a combination of drugs, which is known as a multi-drug regimen. So we refer to this as highly active antiretroviral therapy, or HAART. So here is the schematic diagram to help you remember the steps that we looked at. So first of all, there is binding and interaction of the GP120 and the CD4, then co-expression of other receptors, that's a Ccr5, that's the chemokine receptor 5, and the Ccr4. And so this conformational change eventually is going to lead to fusion, which is facilitated by GP41. Then, of course, introduction of the core of the virus into the cytoplasm. And then, of course, reverse transcriptase will convert the RNA into DNA. Then this is translocated and integrated into the host genome by the help of integrase enzyme, which eventually starts coding for certain proteins that mature off. They make their proteins, and they mature off, they bud off, and they're cleaved off to eventually form a mature virus. Now, each of these steps can actually be blocked. So we can have a drug that's going to be blocking the binding of these receptors, the CD4 receptor to the GP120 glycoprotein. So you have a drug that's known as maraviroc. You have drugs that can actually inhibit the fusion of, or rather, these are called fusion inhibitors. They're going to, or rather, entry inhibitors. Then you have fusion inhibitors, which are going to be inhibiting pretty much the action of GP41. That's a drug that's known as enfuvirtide. We have drugs that can block the reverse transcriptase enzyme. These are of two groups. You have those that are nucleoside or nucleotide reverse transcriptase inhibitors, and the non-nucleoside reverse transcriptase inhibitors. I will teach you the difference of how these drugs works as we go on with this lecture. You have those that can inhibit the integrase enzyme. You call those as integrase inhibitors, and you have those that inhibit the proteolytic cleavage, the protease enzyme, enzyme, which are known as protease inhibitors. So these are the groups of HIV drugs. So you have the first class, which is quite large. The first drug that was ever used or approved for treatment of HIV was a nucleoside reverse transcriptase inhibitor, which happened to be zidovudine. It was approved in March 19 of 1987. So this works by inhibiting reverse transcriptase via chain termination. I'll talk about all these mechanisms in detail very shortly. Then, of course, you have the non-nucleoside reverse transcriptase inhibitors. These are pretty much going to inhibit the reverse transcriptase enzyme by directly binding to it and inactivating it. These are non-competitive. These are competitive. I'll explain also that in detail. The first drug that was approved was nevirapine in June 21, 1996. And of course, you have protease inhibitors, which inhibit the protease enzyme, which is necessary for the catalytic cleavage of proteins that are needed for viral replication and viral maturation. The first drug that was developed was saquinava, which is in December the 6th, 1995. Then we have the fusion inhibitors, which block the entry of HIV into CD4 cells. You have enfuvirtide, which was approved on March 13, 2003. Then, of course, you have the Ccr5 antagonists, which block the Ccr5 receptor on the CD4 cells. Then, of course, this prevent entry of the HIV into the cells. That's a drug that's known as Maraviroc, approved in August the 6th, 2007. Then you have the integrase inhibitors, which pretty much inhibit the integrase and prevent the integration of the viral DNA into the host cells. Then, of course, raltegravir is the first drug that was rather discovered, or rather approved. So this was approved in October 12, 2007. So these are rather recent. The Ccr5 receptor antagonists and the integrase inhibitors are rather recent, as well as the fusion inhibitors. They are rather recent compared to these other drugs that have been there from long ago. So generally, our combination of the ARVs, we're going to be, according to our current regimen as of the 2020, that's the latest guidelines, the 2020 HIV guidelines. Those are the ones I was basing these notes on. So we combine our two nucleoside reverse transcriptase inhibitors. You can also refer to these as nukes. So 2 nukes plus 1 integrase inhibitors. So the regimen that we're actually using is known as the TLD regimen. So tenofovir, lamivudine, and dolutegravir. Then, of course, we can also use 2 nucleoside reverse transcriptase inhibitors plus a protease inhibitors. It's no longer first line for us to actually be using efavirenz. So efavirenz is slowly being phased out from the current regimen. But of course, I'll talk about these things in the next lecture. So let's start with the largest group, which are the nucleoside or nucleotide reverse transcriptase inhibitors. But before I actually go into details of this, let me just show you a black screen, because I want to explain a very, very important concept for you to actually get. So here's a black screen. So remember that in biochemistry, there is something that is referred to as an enzyme. So remember that an enzyme is pretty much a protein that catalyzes a reaction and remains unchanged. Now, the enzyme has pretty much a site where the substrate meets, or the substrate fits. So let's say this here is your substrate, which I shall abbreviate as S. Then this here is your enzyme. In this case, our enzyme is our reverse transcriptase, which I'm going to be calling RT, reverse transcriptase. Then this here is our substrate. These are nucleotides, the one that are labeled S. These are nucleotides that are fitting into this. Remember, you have guanine, you have adenine, you have cytosine, and you have thymine. Now these are building blocks for nucleic acids. They're supposed to fit inside this active site, and this enzyme catalyzes now the formation of DNA from RNA. So what will happen now is you can give a drug that will come. I'm going to draw the drug in blue. So you can give a drug that will come that has a similar shape to the active site of this enzyme, and it will pretty much come and sit in this active site. And then, of course, once this drug here has been now added to the chain, it will cause termination of the chain, because the enzyme will be incapable of actually adding another subunit because of the way this drug has been made. So this is how how the nucleoside reverse transcriptase inhibitors are going to be working. So they look like the normal nucleic acids, but they have been modified in a way. I'll tell you how they have been modified. So these are rather competitive, so they will compete with the substrate for the active site. Then you have another group of drugs which are your non-nucleoside reverse transcriptase inhibitors. They're going to be binding to another site that's not necessarily the active site, and once they bind to the site, they can actually change the conformation of this enzyme such that this enzyme can no longer, the substrate can no longer fit into the enzyme, and therefore the enzyme is actually inhibited or denatured. So this is the two major differences between the nucleoside or nucleotide reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors. I hope that makes a lot of sense. So the first drug that was actually approved, like I said, was zidovudine, which is your prototype drug. These are the first ever class of drugs to be approved. Now, how are these going to be working? They competitively inhibit the reverse transcriptase enzyme by a process that's known as chain termination. Now remember that these nucleosides or nucleotides have a 3' end and a 5' end. This is not a 3 apostrophe. No, it's pronounced as 3 prime as in Optimus Prime. So these nucleoside reverse transcriptase inhibitors, or these nukes, are going to be looking like native ribosomes. Okay, they're analogs of native ribosomes. So they're going to be lacking the 3' hydroxyl group. Remember that the 3' is supposed to be joined by the 5' to form a phosphodiesterase bond, which is pretty much giving you the backbone of the DNA. Without this bond, the chain can no longer be lengthened. Of course, this leads to chain termination, and the nucleic acid that you form is incomplete and it's useless. It can't really, the virus can no longer replicate. So what will happen is that once these drugs are going to be entering into the cell, they're going to be phosphorylated by cellular enzymes, and then this is also going to be once they have been so they are prodrugs. Once they have been activated, then they're going to be incorporated in our reverse transcriptase. Now the reverse transcriptase adds this nucleotide or this nucleotide analog to the elongated chain of the viral DNA. Remember that the 3' hydroxyl group is not present, so you can't form the 3'5 diesterase, 3' 5' diesterase bond. So it means that the incoming nucleoside triphosphate can no longer be added to the chain. That leads to now ending of the procedure. So this is chain termination. So the chain can no longer elongate. Now these are going to be additive and synergistic with each other. They're also going to be additive and synergistic with protease inhibitors as well as integrase inhibitors, meaning that you can combine them with protease inhibitors, you can combine them with integrase inhibitors. Then of course, they are prodrugs, and non-specific kinases in the body. Remember that a kinase enzyme is an enzyme that's pretty much going to be transferring a phosphate group. So they're going to be activated in the cells. Now, because of this, they carry a huge risk of actually causing bone marrow suppression. And remember that the affinity of this drug to the DNA polymerase, which is also present in your host cells, especially in the mitochondria, this can actually happen with certain groups of drugs, especially with these first drugs that were synthesized. So drugs like zidovudine, they can actually bind to the mitochondrial DNA polymerase gamma and cause side effects. This is what is actually responsible for the side effects. So what are the drugs that are in this class? So you have zidovudine, which is also referred to as zidothiamidine. So this is a thymidine analog. You can abbreviate it as AZT or ZDV. So AZT is the much more common abbreviation. Then tenofovir, which can either be abbreviated as TDF or TAF. So there are two preparations. I'll talk about that later on. So this is a cyclic phosphate analog of adenosine. Then you have abacavir, which is abbreviated ABV. This is a guanosine analog. You have lamivudine, which is abbreviated as 3TC, which is a cytosine analog. Then you have emtricitabine, which is abbreviated as FTC, which is also a cytosine analog. So sometimes you may see XTC in the guidelines. So whenever they say XTC, it means that the X can either be replaced by a 3, so it becomes lamivudine, or it can be replaced replaced by an F, so it becomes emtricitabine. Then of course you have stavudine, which is D4T, it's a thymidine analog, and you have didanosine, which is a deoxyadenosine analog. So this is not commonly used. Stavudine, didanosine are not commonly used. Then the ones that are above here are the ones that we commonly use. Now what I was saying is this. You see how zidovudine is a thymidine analog? Then you have didanosine also as stavudine as a thymidine analog. So it means that in your regimen you can never combine zidovudine and stavudine. You can never combine emtricitabine and lamivudine because they are the same thing. They are the same analogs. They are both cytosine analogs. So that's why we usually often are going to be combining abacavir with lamivudine, or abacavir with emtricitabine, or tenofovir with lamivudine, or zidovudine and lamivudine. So what's the pharmacokinetics of this group? These drugs are renally excreted, so all of them are going to be requiring for you to adjust the dose, especially in patients that have renal failure, especially in patients that have renal insufficiency. This is for all the drugs except for abacavir, which is why we in patients that have renal insufficiency and they are taking these nucleoside reverse transcriptase inhibitors, we switch them to an abacavir based regimen. So abacavir doesn't really need a dose adjustment because abacavir is metabolized in a different way. So it's going to be metabolized by alcohol dehydrogenase as well as glucuronil transferase. Now there are some drug to drug interactions, especially with the drugs that are excreted renally. So due to the renal excretion of the nucleoside reverse transcriptase inhibitors, there may not be so many drug interactions except for those drugs which are excreted by the kidneys like zidovudine and tenofovir. Now there is some resistance that can actually exist with this drug. So the resistance actually impairs the incorporation of the analogs into the DNA and also removes the analogs from the prematurely terminated DNA. So the virus has actually learned to actually remove these analogs, or actually remove them from the DNA, or it doesn't even bind to them and doesn't respond to them. So there are often some mutations, especially in the polymerase gene, the PO gene, that codes for the reverse transcriptase, it codes for the integrase, and it also codes for the aspartate protease. So this actually leads to a structural change in the reverse transcriptase. Now one of the mutations is happening at codon 184, and remember that resistance to one drug does not necessarily mean that there's going to be resistance to the another drug in the same class. So cross resistance doesn't really completely happen in this group. So what do I mean? For example, if you have a mutation that is causing a person to be very resistant to lamivudine or emtricitabine, it makes them more susceptible to zidovudine and tenofovir. So when you do your resistance testing and you realize that this patient is resistant to lamivudine and emtricitabine, then you'd want to switch them to either zidovudine or tenofovir. Then of course the cross resistance and antagonism can occur between the same analogs. For example, remember that there are drugs that are thymidine, cytosine, guanosine and adenosine derivatives, or rather they are analogs, not really derivatives but rather analogs. So it means that you cannot combine drugs of the same analog. For example, zidovudine and stavudine. I think I already alluded to this earlier on. So our combinations are pretty much going to be your lamivudine and tenofovir. You have your emtricitabine and tenofovir. You can have your abacavir and lamivudine. Then of course you can have lamivudine and zidovudine, which has now moved to second line. Then of course other drugs are going to include stavudine, but you don't see that in the regimen commonly. Now, what are some of the adverse effects? Remember that the same enzymes or the same drugs can actually inhibit the mitochondrial DNA polymerase gamma, which is found in the mitochondria in certain tissues. So with the deoxynucleosides, such drugs such as didanosine and stavudine, they have a greater affinity for this enzyme, so they can result in side effects like peripheral neuropathy, pancreatitis, even lipoatrophy. Now all the nucleoside reverse transcriptase inhibitors are going to be associated with potentially fatal liver toxicity, so they may cause lactic acid acidosis. They may cause hepatomegaly with steatosis. This is with all the nucleoside reverse transcriptase inhibitors. So we'll start with the drugs. So we have zidovudine as the first drug. So this is a pyrimidine analog. The scientific name is 3'-azido 3'-deoxythymidine, so AZT. This was actually the first drug to be approved for treatment of HIV. So it can be used in adults, it can be used in children, it can also be used in some prophylactic regimens in patients that are exposed to HIV. It's actually well tolerated, can pass through the blood-brain barrier. Then, of course, the dosage is as follows. So we give 300 milligrams orally twice a day, and we can reduce it to once a day if the creatinine clearance is less than 10. But, of course, we should consult someone who's experienced, a senior. Then, of course, in children, the dose ranges between 360 to 480 milligrams. Then, of course, if a patient has a creatinine clearance between 30 to 49, we give them 300 milligrams twice a day. If they have the between 10 to 29, again 300 milligrams twice a day. If they have a creatinine clearance less than 10, then of course this is going to be 300 milligrams once a day. But of course you have to confirm with an experienced clinician, so confirm with your consultant or someone who has training in HIV management. Then of course the half-life is approximately 1 hour within the cell, but rather 1 hour within the body, but then within the cells the half-life is actually much longer, so it's about 3 hours. And most of the drug is going to be glucuronidated by the liver and excreted in the urine. And then both stavudine and ribavirin are activated by the same intracellular pathway, so they should not be given with AZT. Now, some side effects include bone marrow suppression. It is actually quite significant with zidovudine, so you may see things like anemia and neutropenia. So you get a patient that is on HIV treatment and they present to you with anemia-like symptoms, then you should be thinking about zidovudine. There are some things like headaches, gynecomastia, taste disturbances, GIT effects, fatigue, lethargy, neuropathies, pigmentation of the nails, the skin, and the oral mucosa, as well as myopathy. So in all these patients, you have to monitor and do a full blood count after 4 weeks after you start the treatment, and then after that go 3 monthly. Then of course reduce the dose or switch it if the patient is showing some evidence of myelosuppression. The next drug is tenofovir, which is an acyclic nucleoside phosphate analog of adenosine 5' monophosphate. So there are two preparations. There's what is known as tenofovir disoproxil and tenofovir alafenamide. Now, tenofovir is often going to be converted by the cellular enzymes to the diphosphate, which is then inhibited, or rather an inhibitor of HIV reverse transcriptase. And it actually has a half-life, and so it's going to be given once a day. So I'm going to pause the video right here because my battery is about to tap out, so that I can actually change out my battery. So I'm back now, and we can continue our lesson of changing out my battery. So, like I said, it has a longer half-life, and so it can be given once a day, and the drug is going to be excreted mostly in urine unchanged, and the serum creatinine must be monitored, and the dose must be adjusted in those that have renal insufficiency. Now, this drug should not be given with didanosine, but of course I haven't even seen didanosine most commonly in the preparations that we have at the hospital. And what you need to note is that tenofovir is going to decrease the concentration of protease inhibitors like atazanavir, which of course must be given with the boosted form. The boosted form is the one that's going to be consisting of atazanavir and ritonavir if you're going to be using these drugs together. Side effects include things like bloating, nausea, and lipodystrophy. Now we'll start with tenofovir disoproxil, which is going to be abbreviated as TDF. So in adults, you can give it at 300 milligrams orally once a day. In pediatric patients, 8 milligrams per kg orally once a day. So you can either give 150 milligrams, 200 milligrams, 250 milligrams in children greater than 5 years. Now remember that those that have a creatinine clearance that's less than 50, you should actually avoid tenofovir, and rather they'll be better off with an ABC regimen, nabacavir and lamivudine. Avoid TDF in pregnant women. Avoid it in patients who are on rifampicin. Then of course the mutations that may happen with tenofovir disoproxil actually make them more susceptible, make the HIV more susceptible to zidovudine. So they increase the efficacy of zidovudine, which is why now zidovudine was rather moved to a second line regimen, but I will talk about that tomorrow video in the videos to come. Then, of course, our creatinine clearance, if it's 30 to 49, we give 300 milligrams, 8 milligram per kg every 48 hours, so every 2 days. Then, of course, if it's 10 to 29, 300 milligrams twice weekly. Then, if it's less than 10, you should consider 300 milligrams once orally, once a day after hemodialysis. Then, of course, should be given once a week. Then there's tenofovir alafenamide, which you can actually use for those patients that are in renal insufficiency, especially if they have a creatinine clearance that's between 30 to 50. So our dose is going to be in adults 25 milligrams orally once a day, and it's not approved to be used in adolescents less than 10 years. There's no renal adjustment that is needed for this drug, but generally you also want to avoid it in pregnant women. You want to avoid it in patients that are on rifampicin. So here's how to calculate the creatinine clearance, because you have been seeing that all along with your tenofovir, you have been seeing that with your zidovudine. So this is how you calculate it. So our creatinine clearance formula is as follows. So 140 minus the age. So suppose someone is 30 years, so 140 minus 30 multiplied by their weight multiplied by a constant depending on whether they are male or female, then of course divided by the serum creatinine in micromoles per liter. Then, of course, if your creatinine is greater than 50, you can use TDF. If it's between 30 to 50, you should replace TDF with TAF. If it is less than 30, then replace the TDF or the TAF with your ABC regimen and adjust the dose of 3TC. So you put them on ABC and 3TC. Then, of course, if there's any evidence of renal disease replacement, then TDF should be replaced with TAF or ABC. Avoid TAF in pregnant women and patients that are on TB treatment, and also you should increase the dose of dolutegravir to 50 milligrams twice a day. Then, of course, in children that are between 10 to 18 years, then you can use this formula where you say a constant multiplied by the height divided by the creatinine. And here's the conversion from milligrams per deciliter to your micromoles per liter. So 1 milligram is equals to 88.4 micromoles per liter. Your height should be in centimeters, and then the constant is as follows. For girls, 0.55. For boys, 0.7. Then, of course, for pregnant women, use the serum creatinine, and then, of course, it should be less than 125 micromoles to use TDF. Now, you may get some scenarios where you don't have the serum creatinine at where you're working, so you want to obtain a very good history. So ask about the history of kidney disease, history of hypertension, history of diabetes, chronic as well as acute diarrhea, whether it's recent or it's ongoing, use of NSAIDs or any herbal medications. Then, of course, you want to check the weight, check the BP, check the height, check the BMI of an individual. Remember that BMI is your weight divided by your height squared, your weight in kilograms over the height squared. Then, of course, you have your urinalysis, do your RBS and your fasting blood sugar. There are some risk factors for renal disease, things like history of hypertension, high or low BP, history of the diabetes mellitus or high blood sugars, and if they have a BMI that's less than 18.5 or less than 50 kg if they are greater than 19 years. If there is persistent hematuria or proteinuria 2 weeks apart in acutely ill patients or recently hospitalized patients, in patients that are chronically using NSAIDs or herbal medications. If there are no any of these risk factors, then you can start them on a TDF-based regimen. That's your tenofovir disoproxil. Then, of course, you should review them for any symptoms of renal insufficiency after 2 weeks and 4 weeks. Then, of course, you perform your serum creatinine as soon as possible. If these risk factors are present, then you generally want to avoid your tenofovir disoproxil-based regimens without you doing your creatinine clearance as well as your serum creatinine. Now, moving on to the next drug, lamivudine, which is, of course, 2'-deoxy-3-thiacytidine. So the dose is in adults 150 milligrams twice a day or 300 milligrams once a day. In pediatrics, 2 to 4 milligrams orally 2 times a day. Then, of course, this is going to be inhibiting both the reverse transcriptase that we see in HIV and the reverse transcriptase that we see in hepatitis B. So this is a drug that can be used in patients that have infection with HIV as well as hepatitis B. Now, this does not affect any mitochondrial DNA synthesis. It's not going to be causing bone marrow precursor suppression, so it's less toxic. It's actually one of the least toxic and the least potent non-nucleoside reverse transcriptase, or rather nucleoside reverse transcriptase inhibitors, which is why you see it combined with most of these other drugs. It has a good bioavailability when it's given orally, and it depends on the kidney for excretion, but generally it's well tolerated. So in those that have creatinine clearance 30 to 49, you give them 150 once a day. Then those that have between 15 to 29, 150 as a start dose, then you give them 100 milligrams once a day. Then of course those that are between 5 to 14, 150 as a start dose, then 50 milligrams once a day. Then those that have less than 5, 50 milligrams once a day, then 25 milligrams once a day after that. And of course a range between 50 to 70 once a day is still acceptable. Then of course in pediatrics you should reduce the dosage and increase the dosing intervals of the drugs. Of course I'll show you a schematic of the different weights and the different dosages that are there for pediatrics. Then of course side effects include headaches, fatigue, lethargy, pancreatitis, as well as peripheral neuropathy. Then the next drug is emtricitabine, which is the floral derivatives of lamivudine that inhibits both HIV as well as your hepatitis B reverse transcriptase. It's actually well absorbed when it's administered orally. The dosage is 200 milligrams once a day. In pediatrics, those between 0 to 3 months, 3 milligrams per kg per day. It's as a solution. And those with 3 months to 15 years, greater than 33 kilograms, 6 milligrams per kg per day. A solution, so a maximum of 240 milligrams daily, or a capsule of 200 milligrams once a day. Then of course you should adjust them if they have a creatinine clearance between 30 to 49, 200 milligrams every 48 hours. Then the creatinine clearance between 15 to 29, give 200 milligrams every 72 hours. Then those that have less than 15, 200 milligrams every 96 hours, and this should be given after dialysis. Then of course I will show you the dosing of the different weights in pediatrics and the adjustments. And of course the plasma half-life is about 10 hours. And then within the cells it's actually much longer. It's about 39 hours, and it's eliminated essentially unchanged in the urine. It has no significant interaction with other drugs. Then of course side effects include headache, diarrhea, nausea, rash, hyperpigmentation of the soles and the palms, and then of course lipodystrophy. And it's quite, once you withdraw emtricitabine or even lamivudine in patients that have hepatitis B infection, then you may worsen the hepatitis. Then resistance to either your lamivudine or your emtricitabine is actually going to be decreasing viral replication capacity, making them much more susceptible to tenofovir and zidovudine. I think I already alluded to this much earlier on. Then the next drug is abacavir, abbreviated ABC. So this is a guanosine analog. It's well absorbed orally. It is going to be metabolized into inactive metabolites via our alcohol dehydrogenase and glucuronidase, and of course these metabolites can be excreted in urine, so they do not need any adjustments, renal adjustments. So you can give it a 300 milligrams two times a day orally, or in children 8 milligrams per kg twice a day orally. Side effects include GI disturbances, headaches, dizziness, fatigue, lethargy, hypersensitivity reactions, drug reactions, rash, GIT symptoms, malaise, and even some respiratory distress. Now, in patients that actually have hypersensitivity reactions, or those that react to abacavir, those that have been sensitized before, you must never try to re-challenge them, never try to reintroduce the drug, because once you reintroduce the drug, you're going to cause a severe reaction that may actually cause them to die. So if they tell you that I have a history of reacting to this drug, avoid it altogether. You can actually even do a genetic test which checks for the HLA-B5701. This is a human leukocyte antigen. It's a gene that actually we screen for, and once patients we see that they have this present, then most likely that they are going to be reacting to our abacavir. So you want to avoid abacavir in these patients. Now, what is the drug-to-drug and drug-to-food interactions of this group of drugs? So zidovudine and the I presume this should be didanosine, stavudine inhibit our intracellular phosphorylation of each other, so never give zidovudine and stavudine together. Then zidovudine is, of course, hematotoxic, so it causes bone marrow suppression, so its toxicity is actually increased by ganciclovir, alpha interferon, other cytotoxic drugs, even radiation, so don't give zidovudine with these things. Then, of course, zidovudine is antagonistic to stavudine, doxorubicin, and ribavirin. Tenofovir, disoproxil, ganciclovir, and allopurinol are all going to increase the absorption of didanosine. Then, of course, there's increased likelihood of lactic acidosis and pancreatitis with the didanosine and stavudine combination. Then, of course, we don't use these two drugs routinely. Then, of course, you may administer these drugs with or without food, so you can give abacavir, zidovudine, lamivudine, emtricitabine, your stavudine, as well as tenofovir. You may give them with food, you may give them without food. And of course, food decreases the rate of absorption of didanosine, so take it 30 minutes before a meal or when the patient is actually fasting. Then, of course, there are some contraindications. Avoid concurrent administration of the drugs in patients that have pancreatic toxicity, so avoid administration of didanosine, stavudine, or lamivudine. Avoid concurrent administration of drugs associated with peripheral neuropathy like didanosine, lamivudine, and stavudine. Then, of course, in patients that have previous hypersensitivity to any drug, do not administer the drug, especially with abacavir. Now we move to the next group of drugs, which are your non-nucleoside reverse transcriptase inhibitors, or your non-nukes. So these ones are not pro-drugs, so they're not going to be having the risk of myelosuppression. They do not require any enzyme to be activated. They pretty much work by non-competitively inhibiting the HIV-1 reverse transcriptase enzyme. Now, they're not going to be competing with the nucleoside triphosphates. They're not going to be competing with the nucleosides, and they do not require phosphorylation. The disadvantage of these drugs is that they do not work against HIV type 2. They only work against HIV type 1. So what they're going to do is that they're going to bind to another site, an allosteric site, which is hydrophobic, just close to the active site of the reverse transcriptase. And once they bind to this, it causes a conformational change that can lead to the enzyme being actually inhibited. Now, these drugs are additive and synergistic with the nucleoside reverse transcriptase inhibitors, and they include drugs like efavirenz, which is abbreviated EVF. Then you have, EFV rather, I don't know why I'm appearing dyslexic. Then you have your nevirapine, NVP, your etravirine, which is ETR, and delaviridine, which is DLV. We no longer use this drug. It's quite inferior compared to the other drugs and has to be given 3 times a day, so it's rather inconvenient. And of course, drug resistance actually happens in the following ways. So sometimes you may have the non-nucleoside reverse transcriptase inhibitor binding to a pocket next to the active site and actually blocking the polymerization of DNA by the reverse transcriptase inhibitors. That's in the sensitive viruses, but those that have become resistant, they prevent this binding of these to this site, so they allow the DNA polymerase to proceed normally. So that's how resistance actually develops with these non-nukes. So these ones are going to be inhibiting HIV-1 replication. They are inducers, substrates, or inhibitors to varying degrees of the liver cytochrome P450 enzymes. They potentially show some cross resistance with the other groups, and rather the potential resistance with the other groups the other drugs in the same group is quite low and unlikely with the protease inhibitors, because they're different sites and they're different mechanisms of actions. Then, of course, the nucleoside reverse transcriptase inhibitors and the protease inhibitors exhibit an additive effect and synergistic effect against HIV-1 when combined with these drugs. So the first drug that we'll talk about is nevirapine, NVP, which is used in combination with other ARVs in adults and in children, but in adults it's slowly being phased out. We no longer have a lot of patients that are still on nevirapine. Then, of course, it is well absorbed orally The dose is as follows. In adults, we give 200 milligrams once a day for 14 days. Then we give it 200 milligrams twice a day. The reason why you have this 14-day period, it's mandatory that you should have this 14-day period of giving it once a day. Why is this so? Because you're titrating. This is known as a titration, a 14-day titration period, where you're giving half the dose. This actually reduces the risk of your epidermal reactions, your dermatological effects, and pretty much your hepatotoxicity while you're monitoring this patient. Then, of course, for pediatrics, 4 to 7 milligrams per kg orally twice a day. There is no need for adjusting the dose for renal patients, but generally for patients that are on dialysis, give the dose after dialysis. Now remember that is lipophilic and has a wide tissue distribution, so it can actually enter into the CNS. It can cross the placenta and go to the fetus. It can also cross the breast milk. Most of it is going to be metabolized by hydroxylation and subsequent glucuronide conjugation. Then of course the metabolites are going to be excreted in urine. Now one important thing is that this is an inducer of cytochrome P450 3A4 isoenzyme, which is I presume found in the GIT, if I'm not mistaken. So this cytochrome P450 enzyme, once this has been induced, it means that it's going to increase the metabolism of a number of drugs. So you render certain drugs ineffective. So you render oral contraceptives, ketoconazole, methadone, quinine, warfarin ineffective, meaning that if you are co-administering these drugs, you'd have to increase the dose of these drugs or reduce the dose of nevirapine. It makes much more sense to increase the dose of the drugs than to reduce the dose of nevirapine. But either way, you'd have to consult someone who's much more experienced. Some side effects and toxicities include rash, fever, headaches, fatal hepatotoxicity, severe dermatological effects like Stevens-Johnson syndrome, toxic epidermal necrolysis. Then our next drug is efavirenz, which should be administered on an empty stomach to reduce the adverse CNS effects. It's well distributed throughout the body after you give it orally. Most of the drugs is protein bound, bound to plasma at therapeutic doses. Then of course the half-life is more than 40 hours, which is why we can actually give it once a day, either 400 milligrams once a day or 600 milligrams once a day. It's a potent inducer of the cytochrome P450 enzymes, and it may actually reduce the concentrations of drugs that are substrates for this enzyme. The same drugs that I mentioned on the previous slide. Now this can cause dizziness, it can cause headaches, it can cause vivid dreams, so it can cause nightmares. It can also cause loss of concentration. Now, nearly half of the patients actually experience these complaints, but they resolve within a few weeks. And then, of course, rash is another thing that is very common with efavirenz. Then etravirine, which is ETR, is a second-generation non-nucleoside reverse transcriptase inhibitor. Now, this one works specifically for those strains that are resistant to the first-generation non-nucleosides. So pretty much your efavirenz and your nevirapine. Why is this so? Because in those strains, you have a common mutation that's known as K103N. Now, this mutation, what really happens is that, remember that site that was very close to the active site? It changes shape such that now these drugs can no longer bind. But then this molecule, etravirine, is actually quite flexible. Regardless of the different shapes that can be there in that same pocket of the reverse transcriptase enzyme, it can easily fit there and actually block this drug. So in contrast to the other non-nucleoside reverse transcriptase, you need actually more than one mutation for resistance to happen, which is why we actually use this as just second generation drug. So it's indicated in patients that have had a history of HIV treatment, those that have multi-drug resistance to, and they also have evidence of ongoing viral replication despite them being on treatment. Then of course your bioavailability is enhanced when these drugs are taken with high-fat meal. The half-life is about 40 hours. However, we still give the dosage twice a day. So in adults, 200 milligrams orally twice a day. Then in pediatrics, I will show you the different weights. Then it's not approved for children below the age of 6, but it's approved for 6 years. But its approval is actually underway for those that are between 2 months and 6 years. So within 16 kg to less than 20 kg, 100 milligrams twice a day. Those that are 20 to 25, 125, 25 to 30, or 150 twice a day. And then of course it's metabolized to inactive products and excreted in the feces. Then etravirine is actually a potent inducer of cytochrome P450, so rashes are very common. It should not be used with the nucleoside analog. It should not be combine with a nucleoside analog alone because there is a risk of virological failure. So it should only be used in multiple drug combinations with at least 2 other drug classes. So etravirine is actually not recommended for use with unboosted protease inhibitors. So generally we want to give drugs like atazanavir, which has ritonavir with it, so it's boosted atazanavir. Then of course it's recommended to conduct resistance testing before you actually initiate therapy with etravirine. Now, some side effects include toxic epidermal necrolysis, drug rashes with eosinophilia, fever, malaise, myalgias, conjunctivitis, hepatitis can develop 3 to 6 weeks after treatment initiation. And of course, symptoms disappear with discontinuation and corticosteroid therapy. Some drug-to-drug interactions. Remember that etravirine is actually a very potent inducer of cytochrome P453A4 pathway, so it cannot be co-administered, or rather it should not be co-administered with boosted tipranavir. It should not be administered with boosted atazanavir and unboosted protease inhibitors, as well as other non-nucleoside reverse transcriptase inhibitors. Now, the blood levels increase by 17% when prescribed with boosted lopinavir. That's ritonavir boosted lopinavir. And then, of course, this combination may be used but should be considered with caution. Etravirine greatly speeds up the metabolism of Ccr5 antagonist maraviroc. We'll talk about maraviroc towards the end of this lecture. Now, what are some of the non-nucleoside reverse transcriptase drug-to-drug and food-to-drug interactions? Remember that they are inducers of cytochrome P453A, so this increases the metabolism of protease inhibitors, so they should not be combined with protease inhibitors. It increases the metabolism of estrogen-containing contraceptives, even ketoconazole. And then, of course, efavirenz induces the same enzyme, which also has the similar effects to nevirapine. Then, of course, you have the cytochrome P450 inducers like rifampicin increase the metabolism of the non-nukes, so they reduce their efficacy. So you should not combine them if a patient is on rifampicin together with your non-nucleoside reverse transcriptase inhibitors. Then, of course, or rather inducers. Then, of course, the inhibitors reduce the metabolism of nevirapine, for example, so they increase the toxicity. Concurrent use of nevirapine and prednisolone together results in increased incidence and severity of a rash in the first 6 weeks of nevirapine therapy, and so should be avoided. Then, of course, there is reduction of absorption of these drugs with histamine type 2 blockers, and then they may be taken with or without food. And take note that your cytochrome P450 isoenzymes are found in the GIT. They're also found in the hepatic cells. Now, contraindications include hypersensitivity, concurrent administration of the drug that depends on cytochrome P450 for metabolism, and either the drugs that either induce or inhibit the enzyme. Then, of course, concomitant use of the non-nucleosides is not recommended. So do not combine 2 of these non-nukes in one regimen. That's not advisable. And of course, hepatic impairment is seen especially with NVP, so we avoid that. Adverse effects, so you may have fatigue, GIT effects, hepatotoxicity, nervous system side effects like insomnia, somnolence, which is excessive sleep, dizziness, neuropathies, anxiety, psychosis, and even your vivid dreams, your skin manifestations including Stevens-Johnson syndrome. You may also have your NVP associated hepatotoxicity and serious rashes, and these are more frequent in women than in men, and they're more likely to be seen in women with CD4 counts greater than 250 microliters. But of course, now we no longer use CD4 count as a measure of when to start HIV treatment. And the next group of drugs, which is also another large group, are your protease inhibitors. So the mechanism of action is that they block the aspartate protease. So you can also refer to it as retropepsin. It's coded for by your polymerase gene, your PO gene. And remember what this enzyme does is that it's going to be cleaving your precursor polypeptides in the HIV buds to form your proteins of the mature viral coat. So it helps in maturation of the virus. So the enzyme contains a dipeptide structure, which is not seen in mammalian proteins. Then, of course, these protease inhibitors can bind to this dipeptide, inhibiting the enzymes. We may sometimes get resistance that can occur with specific point mutations in the PO gene. And though these are not going to be causing complete cross-resistance between different PIs. Now, these drugs can be combined with the non-nucleoside reverse transcript, or rather the nucleoside reverse transcriptase inhibitors as second line. So drugs like the azidovodine and lamivudine. This is supposed to be nucleoside, not non-nucleoside. Then of course they should be taken with high fatty meals to increase their bioavailability. They are substantially bound to plasma proteins, and all the substrates for the cytochrome P453A4 isoenzymes and individual protease inhibitors are also metabolized by other cytochrome P450 isoenzymes. And of course, metabolism is quite extensive, and very little of the PI is actually excreted unchanged in the urine. So the dosage of these drugs is not, when a patient has renal impairment, you can still give these drugs, in short. Then of course, resistance that happens with the protease inhibitors occurs in a stepwise manner on the protease gene. So the initial mutation is actually going to resulting in decrease in ability of the virus to replicate. Then of course, as the mutations also accumulate, this is going to be, they are going to have a high number of virions that have high resistance to the protease inhibitors are going to emerge. Then of course, suboptimal concentrations of the protease inhibitors are the ones that are actually going to be causing resistance of the strains. And of course, all this ties into adherence and compliance on the drug, as well as the drug dosing, giving the right dose and taking the drugs at the right time. Now, what's the mechanism of action of the protease inhibitors in detail? So remember that in the HIV, the mRNA is going to be transcribed from the provirus, and it's going to be translated into a large inactive polyprotein precursor. Now, the HIV protease enzyme is going to be cleaving the precursor polyproteins to release the structural proteins and the enzymes that are needed to produce the mature infectious virions. Now, remember that the protease is actually needed to form this fully mature functional virus that is able to replicate, that is able to produce more viruses. Now, without this functional protease enzymes, these viral particles that are going to be produced are going to be immature, and they're not going to be infectious. So this is actually a good target for these drugs, because the protease does not occur in the host. We don't have it in our cells. Then of course, the protease inhibitors have a strong affinity for the active site of the HIV protease, and therefore inhibit its catalytic activity. So the inhibition of the protease actually is going to be preventing spread of the infection. Now, the drugs include lopinavir with boosted lopinavir, ritonavir boosted lopinavir. So because of the low bioavailability, we usually tend to boost these drugs with ritonavir. So you also have saquinavir, which is the first drug that was discovered, or rather approved. It is one of the least toxic, and has a very low oral bioavailability, so it's also boosted with ritonavir. You have ritonavir, which is no longer used alone, but usually we use it to boost we use it to boost other drugs. We have indinavir, which is combined with ritonavir nearly almost all the time, with two other nucleoside reverse transcriptase inhibitor, atazanavir, darunavir. Now, what are the pharmacological effects? So protease inhibitors actually inhibit with the formation of essential viral proteins. They are active in both acutely and chronically infected cells. So the chronically infected cells are not affected by the nucleoside reverse transcriptase inhibitors, because the virus would rather be dormant. Then of course, it's active against HIV type 1 as well as type 2. The antiviral effects of the protease inhibitors and some of the nucleoside and the non-nukes are actually synergistic, so they help each other. Then of course, they are metabolized by cytochrome P450 isoenzymes. Then these drugs are going to inhibit the cytochrome P450. So the ritonavir is actually a potent inhibitor of cytochrome P453A4, and it inhibits the metabolism of other protease inhibitors. So it is used to actually enhance the action of the other protease inhibitors. That's why you see that there is a combination of lopinavir with ritonavir, for example. So the adverse side effects, so these are going to be commonly causing nausea, vomiting, and diarrhea. They may cause disturbances in glucose and lipid metabolism, leading to diabetes. So these are the ones that should be avoided with patients with pancreatitis. They should be avoided in diabetic patients. They may cause hypertriglyceridemia. They may cause hypercholesterolemia. Then of course, chronic administration causes fat redistribution. Now, this is very, very important, because those patients that are actually chronically taking this drug, they may have loss of fat on the extremities. Then the fat may accumulate in the abdomen and the base of the neck, and their breast may enlarge. So you can actually tell that someone is actually taking these drugs. So they had this characteristic look that you could tell that these physical changes can actually indicate that someone has been taking HIV drugs. So this is what is known as your interscapular fat pad, or your so-called buffalo hump. What about drug and food interactions? So remember that these are inducers of cytochrome P450, so they reduce the plasma of concentration of protease inhibitors. So any drugs that can induce this are going to reduce the plasma concentration of the PIs. Any drug that can inhibit this enzyme, they're going to increase the plasma concentration of the PIs. And of course, life-threatening reactions can happen if you take them concurrently with amiodarone, lidocaine, tricyclic antidepressants, and quinidine. Then of course, the protease inhibitors increase adverse effect of the phosphodiesterase type 5 inhibitors like sildenafil, which is Viagra. Then, of course, there is increase in risk of myopathy and rhabdomyolysis if they are concurrently given with HMG CoA reductase inhibitors. Then it results in loss of efficacy or serious side effects when given concurrently with drugs that are highly dependent on the cytochrome P450 for metabolism. And the drugs that can be taken with or without food is that. And then, of course, the drug that should be taken with food, atazanavir, lopinavir, saquinavir, and friends. Then, of course, the drugs that should be taken without food is indinavir, so you take it at least 1 hour before or 2 hours after a meal with plenty of water. Then, of course, high-fat meals increase the bioavailability of some of these PIs. Now, contraindications: avoid concurrent administration of the drugs whose metabolism is highly dependent on the cytochrome P450. So avoid giving the protease inhibitors with drugs like rifampicin. And of course, they also avoid it in patients that have hypersensitivity. So we'll start with ritonavir, which is RTV. So this is no longer used as a single protease inhibitor, and it's actually used to boost the activity of other protease inhibitors. Why does it do this? Because remember that most of the protease inhibitors are going to be metabolized by cytochrome P450-3A. So the ritonavir is actually a potent inhibitor of this enzyme. So we can actually co-administer this drug with other protease inhibitors such that we block the cytochrome P450-3A isoenzyme such that now it won't break down the other protease drug, and you have a increased dosage or increased bioavailability of the second protease inhibitors, allowing for longer dosing intervals. So this results in higher minimal concentration levels of the boosted protease inhibitors. It also helps in preventing resistance from developing. And then, of course, the boosted protease inhibitors are preferred agents of treatment in the HIV guidelines. Most of them are metabolized and excreted by the biliary system. Then, of course, ritonavir has a half-life of 3 to 5 hours because it's primarily an inhibitor of cytochrome P450 isoenzyme, has numerous drug-to-drug interactions. Then, of course, it causes nausea, vomiting, diarrhea, headache, circumoral paresthesias, and these are actually the common side effects of the drugs. Then with atazanavir, which is boosted, this is going to be absorbed orally. It must be taken with food because it increases the absorption and bioavailability. It's a highly protein bound drug and undergoes extensive metabolism with cytochrome P450-3A4 isoenzymes. It's actually excreted primarily in the bile, has a half-life of 7 hours, but it can actually be given once a day. So you give it either 300 or 100 milligrams once a day. And then in pediatric patients, we don't have significant data for those children that are less than 6 years. Atazanavir is a competitive inhibitor of glucuronidase and benign hyperbilirubinemia and jaundice can actually occur when you give this drug. And of course, in the heart, it prolongs the PR interval. It also exhibits a decreased risk of hyperlipidemia compared to other protease inhibitors. Then, of course, the unboosted atazanavir is contraindicated when you give it with proton pump inhibitors, and administration with the spaced, you should be spaced apart when you give it, apart from when you're giving it with your H2 histamine type 2 blockers as well as antacids. Then with boosted lopinavir, remember that lopinavir originally has a low bioavailability. So once we give low dose ritonavir to boost it up, this actually increases the dose. So just apologies on this. This is supposed to be 300 milligrams of atazanavir, 100 milligrams of ritonavir. Sorry for that. So even here, this is 400 milligrams of lopinavir, 100 milligrams of ritonavir. This should be given twice a day. Then, of course, pediatrics 10 to 13 milligrams per kg twice a day for lopinavir component. And of course, there's no dose adjustment that is needed. But then in patients that have a creatinine clearance less than 50, you should give them with caution. Then, of course, the GI adverse effects and hypertriglyceridemia are common adverse effects of lopinavir, and of course they are enzyme inducers as well as they should be actually avoided when you give drugs like alcohol, disulfiram, and metronidazole. Once this drug has been admitted or rather administered, then the oral solutions may have these things, and this may actually cause unpleasant reactions in the patient. So generally you should look out for those adverse effects. Then darunavir, the boosted darunavir, this is approved for initial therapy in treatment of HIV, or rather treatment naive HIV patients, those that have never taken any treatment before, and as well as those that have taken treatment before, and those that are resistant to other PIs. Then of course this must be taken with food, as this increases the absorption. The elimination or the half-life is 15 hours. When it's combined with ritonavir, it's given in a ratio of 600 to 100 twice a day. Then of course it's not used for children that are less than 3 years. It's also extensively metabolized by the cytochrome P453A enzymes and is an inhibitor of the cytochrome P453A4 isoenzyme. And adverse effects are similar to those of other protease inhibitors, and darunavir therapy has also been associated with a rash. We'll move now to another group of drug that was recently discovered, or recently approved rather, with those that inhibit the integrase enzyme. So these inhibit and prevent the integration of the viral genome into the host. So you have two important drugs, dolutegravir as well as raltegravir. So the cross resistance between raltegravir and another drug which is known as elvitegravir, I don't know if I've butchered that or really pronounced that quite well. Remember that this can occur although dolutegravir has limited cross resistance to other integrase inhibitors. Side effects include nausea and diarrhea, but aside this, most of these drugs are well tolerated. So begin with raltegravir. So this can be used in combination with other antiretroviral agents, and it's approved for both initial therapy of those that are HIV naive as well as those that have already gotten treatment and they still have evidence of viral replication despite ongoing therapy, those that are not virally suppressed. Now it has a half-life of 9 hours and it's given twice a day. It's actually going to be metabolized by uridine glucuronidase S transferase, which is UGT1A1, and it's going to be metabolized by glucuronidation in short. And so there are going to be some drug-to-drug interactions with cytochrome P450 inducers, inhibitors, as well as substrates that you may see in other drugs. You don't see them with this drug. Then of course, because it's going to be metabolized by UDP, then the dose in adults, 400 milligrams orally twice a day. With rifampicin, you give 800 milligrams orally twice a day. And then I'll show you the dosages for pediatrics. Then raltegravir is well tolerated. There may be some serious adverse effects such as elevated creatine kinase with muscle pain, rhabdomyolysis, and possibly depression with suicide ideation. These things have been reported. Then dolutegravir, which is what we're now using as part of our first line, is actually rapidly absorbed following oral administration. It's highly protein bound. It undergoes extensive hepatic metabolism and primarily also going to be metabolized by uridine glucuronidase S transferase enzyme, and with minor contributions for the cytochrome P450 isoenzymes. Then of course it's a potent inducers and inhibitors of these enzymes can significantly actually alter the concentrations of dolutegravir, unlike with raltegravir. Now more than half of the dose is eliminated unchanged in feces, and nearly a third is eliminated as metabolites in the urine. And then of course it is an inhibitor of the renal transport protein, OCT2. Then it can result in mild, benign, and reversible elevation of serum creatinine. So dolutegravir can be given once daily without the use of pharmacokinetic boosters in patients without pre-existing integrase inhibitor resistance. So in adults, 50 milligrams orally once a day. There is no sufficient data to actually guide its use for patients that are younger than the age of 10. So twice daily dosing is recommended for those that have taken integrase inhibitors before, or those that have strong drugs that are, or rather these enzymes that are going to be breaking down these drugs. Then of course it depends on the specific genetic profile, and some patients with rotogravia resistance, then the mutations can actually make them much more susceptible to dolutegravir. Then the other groups of drugs, so up to this point, the drugs that we've talked about before are the ones that we actually use currently and actively in the treatment of HIV. Now these are newer drugs, and by newer I mean something that was discovered more than 10 years ago, but we don't use them currently in our regimen. So we have the fusion inhibitors, that's enfuvirtide, and maraviroc, which is an entry inhibitor, which is a Ccr5 inhibitor. So we'll start with enfuvirtide, which is T20. So this is a fusion inhibitor, and remember that for HIV to gain access into the host cell, it must fuse with the membrane of the host cell. This is mediated by your GP1 or your GP40. So remember that the enfuvirtide is a polypeptide that binds to GP41 and prevents the conformational change. So this can actually be used to prevent the entry or the fusion of the viral membrane with the host cell membrane. So it can be used in combination with other antiretroviral agents and is approved for therapy treatment in experienced HIV patients who have evidence of viral replication despite them having the antiretroviral treatment. Now, because this is a peptide, you can't give it orally because it'll be broken down by the enzymes in the gut. So it's given subcutaneously, and some of the side effects include the pain related to the injection, erythema, induration, nodules, and this actually occurs in almost all the patients because it's given subcutaneously. So before you give the drug, you must actually reconstitute it. Then maraviroc is another entry inhibitor. So this is well absorbed orally. It is formulated as an oral tablet. So maraviroc actually blocks the Ccr5 co-receptor that works together with the GP41 to facilitate entry of the HIV into the host cells. So HIV actually expresses either your Ccr5 receptor or your Ccr4 receptor, like I said, or sometimes it can express both. So prior to the use of maraviroc, a test actually has to be determine the viral tropism is actually required to distinguish whether this person has a strain that uses Ccr5 receptor or Ccr4 receptors, or it has both receptors. So only the strain that uses Ccr5 can actually gain access into the cell, can actually be successfully treated with maraviroc. So maraviroc cannot work on those that use the Ccr4 receptor, the HIV strain that uses this receptor. So maraviroc is metabolized by cytochrome P450 liver enzymes, and the dose must be reduced when given with most protease inhibitors or strong cytochrome P450 inhibitors. So conversely, it should be increased in patients who receive efavirenz, etravirine, and strong inhibitors of, or rather strong inducers of cytochrome P450. And remember that maraviroc is generally well tolerated. Now, what are the drug-to-drug interaction generally of the antiretroviral drugs? So antiretroviral drugs and oral contraceptives. So some antiretroviral drugs actually either increase or decrease oral contraception levels in the blood. So this can actually either reduce the efficacy or increase the side effects. Then of course, lopinavir, nevirapine, efavirenz may each decrease the oral contraceptive effectiveness. So when one of the drugs is actually part of the regimen, another or even an additional family planning method actually should be used. Then with rifampicin, remember that rifampicin can co-administration with protease inhibitors and non-nukes can actually result in decreased levels of the ARVs. Then of course, decreased effectiveness can actually lead to resistance, and this can lead to also increased liver toxicity. Then of course, ARVs can be used with, you can use efavirenz with the standard dose. Then of course, when used with lopinavir, boosted lopinavir, we should double the dose of boosted lopinavir, and it should not be used with nevirapine or atazanavir with rifampicin. Now, what about side effects and toxicities? I've been talking about this, so I just want to actually distinguish between the two. So a side effect is a negative unintended effect of a drug. They may be mild or quickly passing. They may be serious or long-standing. Then, of course, toxicity refers to the extent, the quality, or the degree of a drug being poisonous or harmful to the body. So both side effects and toxicities are both adverse events. So here are some overlapping toxicities with bone marrow suppression, and here are the drugs: peripheral neuropathy, here are the drugs: renal and kidney toxicity, liver toxicity, and as well as rash. Take your time, get a screenshot of this, and get to learn it. Now here is a drug summarizing the ARV drugs here, the common side effects, as well as what you should do and how you should substitute these. So take your time, actually look at this. I've talked of almost everything that's seen on this slide, so this should actually make a whole lot of sense. And here's the grading of the side effects, the characteristic, and the management of what you do with moderate, with mild, with moderate, with severe, and with life-threatening side effects. So if you have a life-threatening, you want to discontinue all ARVs and manage them medically until the patient is stable and the toxicity has been resolved. Then of course this causes extreme limitation, inactivity, significant assistance is required, significant medical intervention and a therapy are actually required, hospitalization is required. With severe side effects, marked limitation in activity, some assistance is usually required, medical intervention is required, and possibly hospitalization may be required. So here we either refer or consult them, consult a senior, consult someone who's experienced. Then we substitute the offending drug without stopping the therapy. Then if you have the moderate, where they have limitation in activity, some assistance may be needed, no or minimal medical intervention or therapy may be needed. Here we consult, we continue the ART if possible. If no improvement, then we consider substituting with a drug in the same class but with a different toxicity profile. Then if there's a mild thing, which is a transient or mild discomfort, no limitation in activity, no medical intervention needed, then of course we do not need to change the drug, and of course just give symptomatic treatment for the side effects. Here are the pediatric doses and the different weight classes for the drugs that we have available. Take your time, go through this, and you can actually get a screenshot of this. If you really want the PowerPoint to this, just comment in the section below and I'll find a way to actually distribute it to you. And here are the different side effects, or rather drug interactions of the common drugs that you really need to look out for, and the other HIV. Here you have the HIV drugs, and here you have some antibiotics, antimalarials, antifungals, antiretrovirals, gastrointestinal agents, cardiovascular drugs, and some anticonvulsants. Green means that there is no significant clinical interaction. Yellow means that there is a potential interaction. Then red here means that the interaction is likely, so you should not use, or you should use them with caution. Then of course what is it? There's no clear data, and is either an actual or theoretical interaction, and it's not really established. So you go through this bit here. You can pause the video right now, screenshot this, have a look at it, sit down and think through it. It's very easy. Now coming back to our warm-up question, which other test apart from PCR can be used to confirm acute retroviral syndrome? A, enzyme immunoassay. B, rapid HIV 1 or 2 test. C, P24 antigen. D, oral home HIV testing kit. E, Western blot. And as you can see, the answer is Western blot. Remember that with the diagnosis of HIV, if we're using our antigen antibody, we start off with that. Then of course we confirm with our Western blot. We can start off with our ELISA, which is our screening test. Then of course we can confirm with a Western blot test. I really hope you enjoyed this lecture on HIV drugs. If you did, consider subscribing to the channel. Stay tuned as we continue HIV weeks and we learn about the different HIV drugs. My name is Dr. Moses Kazevu, to Zambia and beyond. Until next time, bye-bye.